Yes, I like to welcome you this class as we discuss introduction to chemotherapy. The prerequisite for this course will be your complete knowledge of microbiology and also some level of physiology, anatomy, and perhaps biochemistry. So I believe that the prerequisite has been taken, and also some basic knowledge of pharmacology. If that is so, then we can begin. I'm Professor Sola Omodamiro, the professor of pharmacology and in the Department of Pharmacology and Toxicology, Faculty of Pharmaceutical Sciences, Federal University, Lokojahg. Students, you are welcome. I hope we have a nice working together. Before we start, let's peruse these few issues. Can we discuss? I think we can discuss. And who can answer this question? What is chemotherapy? The second question, what are the class of chemotherapeutic drug? The third question, what is antimicrobial resistance? What we call AMR. And then the next question that is of importance is what is selective toxicity? And then followed by what are the drug targets in chemotherapy? And then what is one head approach? What should be considered before a chemotherapy drug is prescribed? And what are the drivers of antimicrobial resistance? How can he be caught? These are the few questions that is begging for answer. And I believe students are beginning to peruse the ruminating about this fundamental question. I believe in the course of this lecture, the answer will be provided to these various questions. The course outline for this course will include basic terminology in chemotherapy, introduction to chemotherapy, history of chemotherapy, general classification of chemotherapy agents, characteristics of an ideal chemotherapeutic agent, and factors considered before prescribing a chemotherapy agent. That will be the outline for this course. Then let's begin to define some basic terminology in chemotherapy. The first terminology we define and consider is chemotherapy. And chemotherapy refers to the use of chemical, can also be, can use the word drugs to treat cancer and microbial infection. While chemotherapeutic agent or drug refer to any chemical use in the treatment, relief, and prophylaxis of a disease. And then the next terminology of interest is prophylaxis. What is prophylaxis? Prophylaxis is referred to the use of drugs to prevent the potential for infection of a person at risk. What is microbial infection? Microbial infection is any disease or disorder caused by a microorganism, especially bacterial infection, viral infection, fungus, protozoal infection, and etc. What is antimicrobial agent? Antimicrobial agent is any chemical substances that can kill or inhibit growth of microorganisms, regardless of origin. The next terminology that begs for answer is antibiotic. What is antibiotic? Antibiotic is any chemical substances produced by natural metabolic processes of some microorganism that can kill or inhibit the growth of other microorganisms. Natural drug. These are the chemical substances from biological origin that are used to treat infection in their unchanged form. A good example is natural penicillin, Chanconan alkaloids. They are very good example of natural drug. Systemic drug. Systemic drug is chemical substances from biological origin that are used to treat infection when modified in the lab after being isolated from their natural sources. What is synthetic drug? Synthetic drug is chemical substances that are used to treat infection when completely manufactured from the lab. Another terminology that we need to get familiar with is spectrum. Spectrum refers to the range of microorganisms a given drug can effectively kill or control. The range of microorganisms that a given drug can effectively kill or control is referred to as spectrum. And we have two types of spectrum. The first one is broad spectrum. Any antibiotic, that is the one which is effective against a wide range of microbial types, e.g. both gram-positive and gram-negative are regarded as broad-spectrum antibiotic, while narrow-spectrum antibiotic is effective against a limited number or arrays of microbial type, e.g. gram-positive bacteria only or gram-negative bacteria only. Another terminology is bactericidal. Bactericidal, a drug that kills the bacterium, are referred to as bactericidal. And then bacteriostatic drug, a drug that inhibits the growth of the bacterium. They don't outrightly kill the bacterium, but they inhibit their growth. The agent actually interferes with the growth or replication of the microorganism, but do not kill the microorganisms. Another terminology that's of interest is drug resistance. Drug resistance is the decrease in the effectiveness of a chemical therapeutic drug in treatment of a given infection as a result of the causative microorganism developing mechanism that shield it from the toxic effect of the drug. That's what actually constitutes drug resistance. Another terminology that is familiar yourself with is therapeutic index. The ratio of the lethal dose to the effective dose of a drug. It is a measure of the relative toxicity of that drug. How much of the drug that can kill the organism, and then the dose of the drug that can that is effective is actually therapeutic index. So actually, lethal dose divided by effective dose will give you the therapeutic index of the drug. Another terminology is selective toxicity. It's the ability of a drug to kill a harmful microbials without destroying the whole cell. That is selective toxicity. These are the terminology that is sort of need to know. Then we'll be coming across them as we discuss chemotherapy. Student, it's good for you to pay attention to this terminology. You need to memorize them, but make it part of you, because these are the issues that will be of interest even as we discuss. Excuse me. Yes, let's look at what you call therapeutic balance. We have efficacy, toxicity, and then the therapeutic balance. The drug is efficacious, drug is toxic. Must always be a balance between these. That is exactly what is selective toxicity is all about. It's toxic to the microorganism, but it is not toxic. You have a harmless effect on the whole cells. The therapeutic index is actually the toxic dose, what you call the lethal dose, divided by therapeutic dose or efficacious dose. That is how to calculate our therapeutic index of the drug, the antibiotic. Let's pay little attention to antibiotic. What are they? What are they? According to CDS, WHO, the target bacterial infection, they do not work on viral infection. Also, cold, runny nose, flu does not require antibiotic. Antibiotics should only be taken when prescribed. It must not be taken indiscriminately, it must be taken when prescribed. Yes, we need to define this before the what is antimicrobial stewardship? Antimicrobial stewardship program, healthcare associated and nosocomial infection, what is drug resistance, extensive drug resistance, and pan-drug resistance. These are a few words they need to pay attention to. Okay, let's briefly look at the history of chemotherapy. How does chemotherapy, the origin, the history of chemotherapy? Chemotherapy refers to the use of chemical or drug to treat cancer and microbial infection. Before the discovery of an antibacterial agent, large number of people always die from common diseases. Now, many illnesses are easily treated with antimicrobial. However, many antimicrobial drugs are becoming less useful due to development of resistance, which is one of the greatest problems with antibiotic chemotherapy agent drug resistance. By his history, the ancient Egyptian, the Chinese, the Indians of Central Africa, America, beg your pardon, all use mold to treat infected wounds. Mold like fungi, penicillium, tatum, they all used by ancient Egyptian, Chinese, Indians, Central Africa. However, they did not understand the connection, the antimicrobial property of the mold, the treatment of the disease. Some South American Indian chewing the bark of cinchano's tree, especially used for the treatment of malaria fever, especially the Plasmodium species. That's Plasmodium falciparum, Plasmodium malarium, Plasmodium ovale, Plasmodium mosale. Wounds sandal fury with mold, food infection. In 1930, Europeans used quinine, that is the bark of the cinchonus, for the treatment of malaria. Louis Pasteur identified bacteria as causative agent of disease toward the end of the 19th century, while Robert Koch, a German theory, proposed that since the germs are the one that causes disease, then we need to find out how to stop them. In 1877, Pasteur discovered that soil bacteria injected into the animal made anthrax harmless, while in 1888, then Dendrich isolated product from the bacteria with antibacterial property, but were toxic and unstable. While Ulrich in 1910 observed that certain dye stain bacterial cells and not animal cells. So that's where the selective toxicity began to gain popularity. He suggested that this could be used to harm bacterial cells, but not human cells. And through systematic search, he discovered a chemical that could be used to cure syphilis. While Alexander Fleming in 1928 discovered penicillin produced by Penicillium notatum. In 1935, Domach discovered protocols, which is called sulfonamide, with a broad range of antimicrobial activity. René Dobus in 1938 isolated gramicidin and tyrocidin from Bacillus brevis, active against gram-positive bacteria. While in 1942, the manufacturing process for cocaine penicillin was invented by Howard Florich and Ernest Chain. Penicillin could now be sold as a drug. Fleming, Florich, and Chain shared the 1945 Nobel Prize for medicine for their work on penicillin. While in 1943, American microbiology Selma Walkley made the drug streptomycin from soil bacteria, the first of the new class of drug called aminoglycoside. Streptomycin could treat disease like tuberculosis. However, the side effects were often too severe. By 1945, pharmacologists has 5,000 488 derivatives of sulfonamide, sulfanilamide, and sulfonamide. Since 1950, no class of antimicrobial agent has been discovered. Up to today, we are still having many antibiotics coming to the market. Yes, we can just have this as a summary, starting from sulfonamide, penicillin, tetracycline, paramphenicol, aminoglycoside, microlide, glycopeptide, septogranin, quinolone, osasulidinol, cyclic lipopeptide, ketolide, and also glycocycline. They are all launched at different times, ranging from 1936, 1940, 1948, 1949, I beg your pardon, 1950, 1952, 1958, 1962, 1962, 2001, 2003, 2004, and 2005. These are all launched at different times of the year. Here we can see the picture of the various ways by which these were launched. Different antibiotics coming on board at different times. So it's good for you to have a picture of this that form the basic of the history that is behind chemotherapy. I believe that is understandable. Then you can do further reading, get more comprehensive information of history, chemotherapy. Now we look at the principle of chemotherapy. Principle of chemotherapy. What are the drug targets in chemotherapy? How are the chemotherapy agents classified? What are the considerations before prescribing an antimicrobial agent? Patient drug, pathogen, selective toxicity, immunity, prophylaxis, and what are the main mechanisms of resistance to chemotherapeutic agent? What factor actually contributes to the resistance to chemotherapeutic agent, such as antibacterial? These are the things we'll be looking at. So we put our satellite principle of chemotherapy. So the general classification of chemotherapeutic agents includes antibacterial, one that specifically attacks bacteria, antibacterial drug, antituberculosis, or antimycobacterial drug, also anti-leptic drug, those drugs that attack tuberculosis, mycobacterium leprosy, mycobacterium tuberculosis. Also, we have as a classification anti-protozoa drug. It's one that attacks the protozoa, antifungal, antiviral, anti-hemetic drug, and then anti-cancer, which is also called anti-neoplasmic or cytotoxic drug. These are the 7 classifications that we will pay attention to. And of course, the classification of these antimicrobial, we have antibiotic, which it can also be called antibacterial. We also have antiviral, antiparasitic agent, and also antifungal. That is the classification of an antimicrobial agent, antibiotic, known as antibacterial, antiviral, antiparasitic agent, and then antifungal. The chemotherapeutic spectra. As we have already discussed, we have a narrow spectrum. The narrow spectrum only against a single or a limited group of a microorganism, either gram-positive or gram-negative organism, like isoniazid. is active mainly against microbacteria. So it's regarded as a narrow spectrum antibiotic, while the broad spectrum antibiotic affects a wide range of microorganisms, both gram-positive and gram-negative. A good example is tetracycline and then chloramphenicol, which affect a wide range of microbial species. We actually altered one of the disadvantages of this broad spectrum, they altered normal bacteria flora, which end up precipitates what we call super infection or supra infection of an organism, especially Candida. Yeah, thank you. Or Candida albicans. Then the next spectrum is extended spectrum. Extended spectrum. They have a lot of wide range of antibiotics. So let's look at the categories of antimicrobial therapy. We have prophylaxis, we have preemptive, we have we have definitive, we have suppressive. What we mean is prophylaxis, no infection, but we are just trying to prevent infection. While the preemptive, that's infection, we are trying to eradicate it. And this one, you're eradicating the symptom. This one, definitive, actually pathogen that have been isolated, then the suppressive is okay. Yeah, clinical uses of antimicrobial. The first consideration in selecting an antibiotic agent is whether it is even indicated. Empirical therapy, definitive therapy, and then prophylactic therapy. So selection of empirical therapy, the treatment of severe infection, and particularly of the mucosomia infection should be based on accurate strategy. In the first phase, what should be made in order to target the antimicrobial therapy. And then it is important to begin an empirical therapy, especially against gram-negative bacteria, which are responsible for many severe infections, where delayed therapy is related to increase in mortality. So let's end up with this part of our study. So thank you very much. So we meet again. As we continue. Thank you.